Hello?
Hello.
Oh, hi.
Hello.
Sorry about that. The other link was sending me to an empty Hangout, but
Right.
Oh,
the original
right.
one.
We apologize for the delay.
Oh, no problem. I was a bit late as well. So there's the two of you in the group?
Yeah, it's
Okay.
just us two. I'm Aaron, by the way, and this is
I'm Leona.
Leona, nice to meet you. I'm Azad.
nice to
Nice
meet
to
you.
meet
You know.
you.
Well, we can jump right into the
Sure.
interview straight away. We think it'll take around more or less 40 minutes just to complete the interview.
Sure.
And yeah, we just want to discuss a bit about your medical practice and about your engagement with 3D technology.
Okay. Great.
So I guess we can start. Can you tell us a little bit more about what your practice is, specifically involving your work in cardiac anesthesiology and perioperative echocardiology?
So I'm an anesthesiologist. Most of my practice is cardiac. So I give anesthetics for cardiac surgeries, usually a couple of surgeries a day.
And
Can you guys hear me?
yeah.
Yep.
Okay, I lost the video, but I'll keep talking.
Okay.
And in addition to working in the operating room, I also cover the cardiovascular intensive care unit. So that's sort of a week at a time, roughly 1 out of every 3 or 4 weeks. And that's patients who've had heart surgery who, for the first few days after the surgery, require intensive care and closer monitoring. And once they're out of that window, then they go up to the floor and they progress on their way to the rest of their recovery. My connection with 3D modeling and printing comes from the fact that we do echocardiograms on most of these patients. So both during the surgery for a lot of the cases, but also if we're concerned about what's happening with the heart when they're in the CVICU, we use echocardiography, so transesophageal echo. So the probe goes into your esophagus and we do an ultrasound of the heart from the back.
Mm-hmm.
But most of the time when we use, this is usually with 2D slices, so you get a two-dimensional image, and we can rotate a plane through the heart and move it up and down and get different views of different structures. In the operating room, we occasionally also use 3D echocardiography, so we can actually get a whole volume data set. And the advantage of echo over other modalities like CT is that, one, there's no radiation, but also it's very useful for point of care. So we're in the operating room, you don't have to have a big CT machine, there's no radiation, and you get very good time resolution. So we can get images that are 40, 50, 60 hertz resolution. So if we're looking at very dynamic structures like heart valves that we're repairing, we can get quite good images. The downside is that you have limited spatial scope. So the ultrasound only penetrates so far, and at any given time, you're only looking at sort of a 90-degree wedge at most, or potentially smaller. And there can be a fair bit of artifacts and noise from other sources, both if there's anything in a patient's heart that's metallic, like if they've had a former valve, or if they have a lot of calcium, those things can cause artifacts. If there's any bit of lung coming in between the ultrasound probe and the heart, that air prevents the ultrasound transmission. But the other work that I do with 3D is more assisting with surgical planning. So this is mostly CTs, so cardiac CTs that are gated to the cardiac cycle, so that you get very high resolution images of a heart, but a heart that's sort of held still. So they're not dynamic images. And we use these models to make 3D digital models, but also potentially prints for surgical planning. At this hospital, we have a pretty large population of adult congenital heart disease patients. So patients who have been previously been looked after at sick kids.
Right.
Once they reach adult age, they come here, and a lot of them need various procedures. So, for example, they have rhythm problems in the heart, and because they've had previous heart surgeries, there are scars and things in the heart that cause erroneous rhythms, so that their heart can go suddenly very fast. And the way this is treated often is by these minimally invasive procedures where they go in through one of the big veins, and they go into the heart, and they burn a line around the part of the heart wall that's generating the bad rhythm. So even though the bad rhythm is generated there, it can't spread to the rest of the heart. And they have to do it very carefully. They do this for people without congenital heart disease as well. And in those cases, the anatomy is more predictable. But with patients who've had previous heart surgery, especially multiple ones at a young age, it's much more difficult to do this safely. So even though they use some image guidance at the time of the procedure, for these patients, it really helps sometimes to have these printed models before so they can plan which direction they're going to approach from and where the hard turns are going to be, etc., and how close they're going to be to much more critical structures that they don't want to damage. The other thing we use 3D models for is for education. So I teach echocardiography to our fellows, and for that I print a lot of 3D models of the heart based on CT primarily, but occasionally on ultrasound as well, that I use for teaching. And we've been working with making echogenic models out of these hearts. So actually printing the hearts and then casting them out of material that you can ultrasound so that we can actually teach ultrasound on a heart model with the real ultrasound machines. I'm also looking at other applications for education. So we've made some spines, for example, that we've 3D printed for practicing epidurals and neuraxial anesthesia. So that's when you inject anesthetic around the spine, either for labor or for some surgeries, where we can free someone from their stomach or their hips down for surgery. We've made some models for bronchoscopy, so models of the trachea going into the lungs. Can you guys hear me still?
Yeah,
Yeah, we can.
hear you.
Okay.
Very.
So that's making models of the trachea and the branches into the lungs. And our trainees can practice looking down with a scope, because oftentimes with patients who have bad pneumonias, we have to all look down and get samples of the infectious material from the lungs.
Right. Wow.
But my long-term research interest is looking at ways of using these techniques, both printing and also modeling, and virtual reality and other ways of interacting with 3D models for education, but also to make surgery safer.
Really interesting stuff.
That's really interesting stuff. So we're just trying to get more of an understanding of your day and what you do on a day-to-day basis so that we can try to find a solution for a need that we might gather through this conversation. So if you could describe just your everyday, like basic day for us in as much detail as you can.
Okay. So my work days can be different. Depends on if I'm in the ICU or in the operating room.
Okay.
There's a lot of feedback.
Sorry.
There's a lot of sound feedback on the line.
Oh, I think it's the more we talk and it switches.
Okay.
And so we'll try to be more silent. Yeah.
Oh, sorry. So when I'm in the operating room, I usually work with two rooms, and I have a fellow or senior resident who is in each room with a patient. And so they're there the whole time, and I go back and forth, and I'm there at the critical times. And they can call me if there's any concerns that they have. So usually one of those rooms is the cardiac surgery room, and the other one is something that's lower intensity. So I would come to the hospital around 7:30, check to make sure that the room has been set up, that the fellow and the resident are okay with getting the cases started. The surgeries begin around 8 o'clock. So the patients come into the room at 8 o'clock, and then we have to put the patients, just do the safety checks, put the patients to sleep, do any other procedures that need to be done initially, like getting central lines that have to go in the neck, other sometimes arterial lines, so various other kinds of vascular access that we have to do. For cardiac surgeries, we almost always put a central line in the neck, and through that, what's called a pulmonary artery catheter that goes through into the heart for measuring pressures in different chambers of the heart.
So I'm just wondering, what is involved in the safety check that occurs with the patient?
So the safety check is protocolized by checklist. So there's the initial stage before the patient goes off to sleep. We check to make sure we have the right patient, the right surgeon, the patient's having the surgery. We think they're having, if anything that's lateralized, like if it's a leg surgery, you make sure it's the right leg or not the left leg, etc. We decide about perioperative antibiotics, perioperative anticoagulation. For heart surgery, there's often high need for blood transfusion. So we make sure that the blood bank has the right information that they need, that there's blood available for the patient of the right type. And there are different ways of accessing the blood, so we check to make sure we know the right channel to access the blood for this patient.
Okay, perfect. Sorry, continue. Yeah.
Then we induce the patient, so we give the patient the induction medication, they go off to sleep. We put a breathing tube in, and so this happens before we put the lines in. So once the patient sleeps, then we put the central line in. Then we take some blood samples that we run some tests on just to get some baseline values, and then we compare them to values after the operation. And then the patient they sterilize the area that they're operating on, and the surgeons sort of take over and start operating. And at that point, we're just monitoring the patient, giving medications to adjust blood pressure, making sure they're getting enough anesthetic. So we're monitoring sort of heart rate, heart rhythm, pressures in the different heart chambers, with the gas exchange, so how much oxygen is going in, how much carbon dioxide is coming out, and all those levels we have to maintain. So we have to adjust the ventilation levels. If there's problems with blood pressure or the heart's weak, we are giving medications to support that, and we'll keep taking measurements and adjusting those medications. We adjust the blood sugar, look at the hemoglobin, see when the patient needs to have a blood transfusion, measure the temperature, adjust the heating and cooling of the patient. And then some medications have to be periodically redosed. So there's medication that keeps the patient paralyzed, so they don't move during surgery if there are any reflexes. That medication has to be controlled and redosed. The antibiotics have to be given periodically to prevent any infections. And then in different surgeries are different critical points. Did you want to do a question?
You can continue. Sorry, no, you can continue with, unless you're done with that question.
No, I mean, I can continue.
Oh yeah, okay.
So different surgeries have different critical points where there may be we expect a sudden change in either the patient's blood pressure or some other vital sign, because sometimes the surgeons have to block a major artery or block a major vein that's going to affect how the heart's working, or they're going to do something that's going to affect how the lungs are ventilating. So at those points, we have to pay special attention, communicate with the surgeons, make certain adjustments. So in cardiac surgery, the big thing is going on cardiopulmonary bypass. So at some point, we have to give patients a large dose of anticoagulant medication so the blood doesn't clot anymore. And then they put in cannulas in the big vessels of the heart. And instead of the blood going through the heart and coming out of the heart, the blood gets sucked into these cannulas, goes into the bypass machine, and then it comes back to the aorta. And the heart becomes empty so they can operate on the heart. So that transition is very important. And we have to monitor the patient closely and make sure we have the blood pressure in a very narrow interval where it's safe to put in these cannulas. Once the patient is on the bypass machine, that's sort of a bit of a break for us, because then there's a perfusionist that looks after the bypass machine. And we communicate with them about the measurements they're taking. But at that point, they manage the blood pressure and things like that. Then we sort of catch up on our documentation. So we have a charting system, and we make sure we document the drugs that were given, all the other, how the procedures were done, if there were any complications. And then the next step is when they're coming off bypass. So when the surgery is done, then we check to make sure that the patient has the right body temperature, that we can still ventilate and give oxygen to the lungs, that we can oftentimes use a pacemaker for the heart after the heart surgery. So we make sure the pacemaker is working, and once all these criteria are met, then we transition back from the bypass machine to the patient's own heart. So we let the blood flow through the patient's heart again. Then usually there is some period where the patient's sort of bleeding a little bit. We reverse the anticoagulation. We address any parts that are bleeding. And then when the surgeons are satisfied, then they close off the patient and we go to the intensive care unit. If there's an ultrasound being done, once the patient is asleep, the ultrasound probe goes in. And while the surgeons are getting set up, we do an ultrasound of the heart baseline. And when after we come off the bypass, we look at the heart structure again that was operated on, and see if the repair was successful. And we look at all the adjacent structures, obviously, to make sure they haven't been any unexpected complications, any other problems. So the patient then goes to the intensive care unit, we drop them off, and then we come back and do the next case. So usually there's 2 cases for heart surgery in a day. If I'm doing the intensive care unit, then I'm responsible for about 15, 20 patients that are in the unit. So we start at 7 in the morning. We take a quick handover around the desk from the person who was covering the night shift. So they give us any issues that happen overnight with the patients. Then we go around and we see each patient roughly between 10 and 20 minutes per patient. And we do a full review of all the on what's been happening with the patient, address all the issues. We have certain safety checklists that we go through to make sure we've addressed a lot of common safety concerns. And we've done a lot of work around optimizing this workflow and developing special forms and things to make it go more smoothly and for us to not miss any details. Once that's done, we sort of have a list of what needs to be done for these patients. Additional lines may need to be done. Certain consultations may need to be made with other specialties. Certain procedures may have to be done. And we also get new patients coming from the operating room for that day. And we have certain patients who've been there long enough and they need to go to the floor. So we have to write transfer orders and paperwork documentation for them to be transferred. And then we round again once in the afternoon. So by the time all the new patients have arrived, we do a full round on all the patients in the unit. And then everybody else goes home. The people who are covering for the night stay. And so as we're needed, the nurses will let us know, and we check up on the patients that are most labile and that we're most concerned about. So and sometimes if we're really concerned about somebody, they might do an ultrasound. So we might do an echo on the patient in the CVICU to see what's happening.
Okay. So you've already mentioned quite a few technologies that you're using in your everyday practice. That was quite a list. But we were just wondering what maybe the primary technologies that you engage with, depending on whether you're in the ICU or otherwise.
So the primary technologies that we engage with are various information and data management. Some of them are as basic as the technology of the patient binder that has different forms and dividers. Then we have our computer systems, the certain forms of documentation that they keep, some on paper, some electronically. The electronic data systems that we use, we have a patient chart that has all the blood test results and old letters and dictations and notes from other physicians. There's a separate system for the medical imaging that's for x-rays and chest x-rays and simple imaging. There is still a separate system for all the ultrasound images and echoes. And there's a huge amount of time wasted going back and forth between these systems. There's a lot of inefficiencies because these systems don't necessarily interface well. Each of them individually has significant ergonomic problems. So for example, if I want to know for sure every medication that a patient receives in a 24-hour period, I have to check in 3 or 4 different places. And even then, I can never be quite sure that I have all the medications accurately.
So this is in regards to patient data that you're saying is on different interfaces for you?
Yes, on different systems. Yeah.
Okay.
Right. All with their own interfaces.
Are these information technologies used across the board in other clinical practice areas, or are they specific to what you're doing?
So most of them are used to various levels. So the patient chart is used everywhere. Both the binder chart and the electronic chart. The imaging systems, the one for x-rays is used fairly widely. The one for the echocardiograms is used mainly by us in anesthesia and ICU and the cardiologists.
So this isn't even a concern of patients coming from like different hospitals, and that's why they have different data, and so you can.
No, that's a whole other.
Yeah. Okay, that's a whole.
So if we get patients who can transfer to us, or who've had a test done somewhere else, there's a lot of problems getting access to that data.
Mm-hmm.
Right. So you mentioned that when you work in the ICU, the patients get about 15 to 20 minutes, and then if they need ultrasounds or anything further, then are they passed on to a different doctor to perform that, or is that?
No, that usually also once we finish rounding, we come back and somebody on the team will do that. Okay. So when I'm in the ICU, I have usually 1 or 2 clinical fellows, fully trained physicians who are just getting more clinical experience. and one or two residents who are more junior. And then each patient has their own trained ICU nurse.
Okay. So our next question might have already been answered, but I was going to ask what task do you not really look forward to doing in a day? And I'm not sure if that is trying to find all the different types of data that you can't really find by going to different interfaces. But if you were to pick a task that you really didn't look forward to doing every day, what would that be?
I think it's doing all the data and all the documentation we don't have to do, which is also similarly in multiple places.
Okay. Are all the interfaces that you used run by different like sub software companies or sub like hardware companies?
They're all originate from different vendors.
Okay.
Locally, they're mostly administered by our IT department, which has its own long history of institutional dysfunction.
Okay.
The system that we use for our ultrasounds and echoes is administered by separate sort of cardiac IT department.
Okay.
But one issue is sort of inter-vendor incompatibility. The other issues are institutional design handling this stuff. And we don't have all this stuff on paper that somewhat overlaps with the functionality of the electronic systems. And it's very easy to forget, even after being here for a while, what has to be done on paper, what's computerized, what was computerized this week that wasn't last week, etc.
Are a lot of things done on paper currently, or are there just a few?
There's a lot of things that are done on paper.
Oh, there
especially when a patient is seen by another specialist group. All their notes and documentation are done on paper. The ICU nurse's charting is done on paper. A lot of the investigations, the reports come back on paper and aren't necessarily on the computer if they've been done elsewhere.
Does someone then have to transcribe all this information to a digital place, or does that not happen?
No, so it all goes into the patient's chart, which is a big binder. When the patient is discharged, these get scanned into the computer system. So documents from previous admissions can be accessed as images, but they can't be searched. They can't do like a free text search or something.
Right.
You have to know roughly where it is, and then you get the sort of image file that's organized in the same scheme as the binder, and then you go look for it and you flip through the images.
Okay. So there's multiple doctors that could be working on this one patient, so they're all using this one chart all the time.
Yeah. And oftentimes finding the chart, for example, is a problem. Somebody else is off of it.
Okay. I could see how that's daunting. That makes sense as a task that you wouldn't look forward to doing every day.
Are there any other issues that you think arise from that disconnect between the analog and digital kind of collecting information?
There's short-term safety issues. This information can easily be missed, and sometimes in an emergency, you can't access information fast enough. And you have this adding to the burden of work. People who are already overworked. So especially late at night, on night shifts, becomes even more frustrating. And a lot of unnecessary duplication. And at the end, because it lacks indexing, finding information quickly is quite difficult.
Are a lot of the doctors at computers like really regularly? I'm just trying to think about why it wouldn't have been digitally transcribed in the first place. Is it because there are just all the information's coming from different vendors and it's easier to just kind of print it off and put it in a chart?
So I think no, so the information, we have multiple computer systems and then the paper chart. So we rarely print stuff from the computer and put it in the chart.
Right.
But if the patient comes from somewhere else, they might have that done. But most of what's in the chart is stuff that's handwritten. That's going in the chart. But there's a lot of that stuff that's handwritten. And there's issues with handwriting, reading people's handwriting. But this happens probably because we don't have a single computer system that can handle all these different functions. And there's been attempts of individual hospitals, but also provincially to have a standardized system across the province, but there's been various problems implementing that. There are vendors that produce systems that do all these things, but they're extremely expensive.
They're expensive, yeah.
So we recently went through an exercise where we evaluated one ad length, and it was quite costly, but it had to be abandoned eventually because they realized that the cost was going to be in the billions of dollars to implement one.
Right. Okay.
So returning to a bit more about the 3D printing technology, 3D printing and virtual reality technologies that you use. My question is, how do you incorporate these technologies into your everyday ICU practice, or do most of those technologies remain in an educational model, or when you're doing a kind of educational practice?
So most of my applications right now are educational. So when I'm teaching in the ICU or when I'm teaching in the operating room or giving lectures, I try to use digital models or prints. Most of the models that we make for clinical use, I make for other practitioners. I make for surgeons might request one, or cardiologists might request one. Because I'm an anesthesiologist, so I don't do very many direct interventions. And the interventions that I do are usually putting in access lines, things that we don't use any 3D modeling for. Because sometimes we often use ultrasound to image guide the procedures. But yeah, most of the applications, daily applications are educational.
In terms of VR, because I know you said you were also interested in that, is there an idea or like something that you've been thinking about specifically regarding your practice and virtual reality?
So one of the things we work on is heart valve surgery. And when patients come in for heart valve surgeries, we get these 3D ultrasound data sets of the heart valve. We can get them pretty quickly. And we have some automated programs that can actually segment the ultrasound data and give you a 3D model that's pretty accurate pretty quickly. But we're trying to find a way of giving the surgeons access to this model. And we can put it on a two-dimensional screen and have them rotate it, but they don't find that all that helpful. But a couple of times we actually managed to get these models into a VR system and put a VR helmet on them. They've been very impressed with how much they could see. One of the issues with valve surgery is a lot of valves get replaced, which is relatively easy, but repairing valves is quite difficult. And a lot of times that difficulty, because of that, there are very few surgeons now that do valve repairs as a proportion of all cardiac surgeons.
Hello?
Hi.
Sorry, I
Apologies
think our
for that.
internet just cut
Yeah,
out.
our internet-
I was trying to figure out if it was yours or mine.
Oh, okay. I
Okay.
think it was
Okay.
that.
Okay.
Great. So,
Sorry about that. You were talking to us about how virtual reality applied to what you were doing.
Oh, so when we try this, so repairing valves is very difficult because when the surgeon's operating, the heart's empty and the valve is all collapsed and it's very soft tissue. So they can't really see the three-dimensional structure of it very well. Can you still hear me? Because your image is locked. Okay.
yeah, we can still hear you.
Okay. So part of the reason why we do these ultrasounds pre-op is for the surgeon to actually see the heart, see how the valve is functioning when the heart's full, and based on that, identify what the problem is and how they're going to repair it. But it's very difficult for even a very experienced surgeon to look at this image and then be able to translate their plan onto a floppy heart valve in the empty heart. So if we can actually allow the surgeons to see the valve 3D model in virtual reality or in a print, the problem with the print is it usually takes too long to get a good quality print before they need it. But the VR we could process very quickly. And based on that, they can identify where the problems are and plan what they're going to do. And then ideally the next step would be if they can actually, on the virtual reality, make the repair, and we could simulate how their repaired valve would function so they can evaluate whether the valve can be repaired or not. Because one of the other limitations is that if you think the valve can be repaired but you're not sure, then you run the risk of taking the time to repair it, having the repair not work, then having to repeat the bypass run for the patient to replace the valve. And there's a lot of risk with every additional bypass run. So the risk of having a stroke or any other major complication goes up significantly every time you go back on bypass. So a lot of surgeons, because they're not sufficiently confident of their plan, will choose to replace a valve that could potentially be repaired. And we know that long-term patients who have repairs do a lot better with repairs than with a well-done repair than they would with a replaced valve. The replaced valve, mechanical valves, or even biprosthetic replacement valves have a lot of complications in the long term that a well-repaired valve doesn't. So we're trying to find ways of using 3D modeling to help the surgeons repair a lot of valves that they're currently replacing.
Right. In terms of like the local hospital community or the surgical community, has there been any pushback regarding incorporating these type of new technologies into the medical practice?
So the 3D ultrasounds we use routinely for all the valve cases, and it's been an excellent part of the practice. We've only worked with the 3D models with a couple of the neurosurgeons that we have. There hasn't really been any pushback, and I think where there would be pushback is if it took them any longer to do the surgery. Right. So what we're doing delayed the procedure any longer. So far, we haven't used it in any used the 3D models in any actual cases. We've just shown it to them outside of the operating room, had them sort of evaluate it and tell us whether they think it would be useful. Some of our we have a couple of sort of very exceptional, very experienced surgeons who probably wouldn't need this anyway. They can do all this in their head. But those are relatively rare individuals. So we're trying to make this technique much more accessible to a sort of broader audience of surgeons.
Is there something that sparked your interest in the use of new technology in terms of 3D printing or virtual reality? Was it something you were just always interested in?
I've always interested in sort of building and visual things, and I've done painting and drawing for a long time, and I was drawn to medical imaging for that reason and the applications of imaging. And I'm a visual thinker, so for me, I can understand things better when I can picture them. So I would often make illustrations and drawings and models for my own learning. So and I find it much easier to communicate with my students if I have an image in front of me and I can, or a 3D model in front of me. Okay. But also, my undergrad was in artificial intelligence, and I was interested in sort of computer programming and things like that. So just kind of married all those things together.
Okay. Very cool. Could you tell us a bit about some of the kind of more prevalent issues within incorporating those technologies into surgical use? Are there any kind of discourse issues or issues that are being kind of widely discussed in that regard?
There's some conceptual problems in terms of people not necessarily being able to imagine what the benefits are. And that's always an issue with new technology, is having the vision to see where it can potentially go. The other one is the way that business models are currently set up. Medicine there's a lot of money in medicine, there's a lot of money in medical devices, and the problem development model is if you have a good idea, as a clinician, if you come up with a good idea for something new, the current model is you put something together, then you find a venture capitalist, you patent everything up, you get a startup going, you try to market it, but oftentimes the locking up sort of kills it. So unless your idea is so big that everybody has to use it, a lot of times by the time the thing makes it to the field, it's so expensive that only a few centers can use it, and most of the patients who would potentially benefit from that technology don't benefit from it. I'm a stronger believer. I'm primarily an academic. I want to do things academically, and access to knowledge and getting knowledge out there is much more important to me.
Right.
So one of our, so far, most applications of 3D printing in hospitals have been driven by the 3D printing industry, and they come to the hospital and they say, "Oh, this is healthcare. It's very important. The precision is very important. It's really important that you buy this 16 micron, or 2 micron printer, which is the best in the industry, and it costs $2 million to buy this, and each print will cost you $500. But this is healthcare. It's important. You want to do the best for your patient." Never taking into account that the imaging source you're using has a resolution of 0.5 millimeter, right? So a $300 desktop printer gives you as good a print clinic from a scientific standpoint. It may not be as pretty, it may not be as shiny, may not have as many colors on it, but there's no reason why you need anything more than a desktop printer. So our lab runs entirely on TAS 5 machines. So our most expensive printer is $3,000. And because the individual prints are so cheap, we can do a lot more playing around and experimenting. And so like our lab is a bit like the Willy Wonka chocolate factory, with all these things being molded and different things and we can pursue a lot of ideas very cheaply.
Okay, so our last question is about the T technologies. We were wondering about your challenges and limitations with teaching other clinicians on that.
I missed the last part of your question.
So we wanted to know about the challenges and limitations that you have teaching other clinicians on how to use the T technology.
The TE, like
the TEE, yeah.
Or the T.
Yeah.
There's actually one problem in the general workflow of taking T images and printing them, sort of a side note, is that so medical imaging has a standard called the DICOM standard. And the DICOM standard was introduced to make medical imaging data vendor independent. So no matter who made your CT scanner, the data would have to be in the standard format so people could share it. Unfortunately for 3D, because 3D ultrasound is a new modality, the DICOM standard didn't really define the data encoding very well. And attempts by the DICOM group to sort of define the standard have been cut off by these companies. So right now, even though you get a DICOM file, depending on what machine it came from, it's going to be encrypted by that manufacturer. So we have Echo machines that are by GE and Echo machines that are by Philips. So the Philips one has a different encryption, the GE one has a different encryption. Philips sells us a program for $10,000 a year that lets us decrypt the data and use it for these 3D models. GE makes no such program, and even for Philips, unless you're a big hospital like us and have the money to buy this program, you can't use this data for any kind of modeling. That whole process of teaching people how to do this is complicated by a lot of these technical factors, and some of these technical factors are made unnecessarily complicated because of all these attempts by companies to lock down the data at various points. So the workflow of taking a 3D echo to print can be about sort of a third as complicated as it is now. If you removed all of the proprietary encryption steps, And one of the problems, even within one vendor, so say Philips, depending on what generation of machine you have, our version of the software, which is the latest version, may not be able to open it. We may have to actually go and get an old version to open an older file. They don't even have that kind of backward compatibility with their own products. In terms of teaching how to use TE, one of the problems is TE is quite invasive. So for regular ultrasound, it's done on the outside of body, so we can easily get patients who are sitting on the board to volunteer and tell them this is a student, he's going to have a look at you. It doesn't hurt them, there's no risk to harm to the patient. For TE, because the probe goes in the esophagus, there is risk of tearing in the esophagus and causing damage, so we can't just ask a patient to submit to this as a charity for education. But at the same time, we have to teach people. So what happens, the traditional technique has been that first you get familiar with the views by looking at images. Then you kind of play with the probe outside of a patient and see what happens to the tip of the probe when you move the controls. Then you watch, then with somebody supervising you over your shoulder, you start acquiring images yourself and putting the probe in a patient, which is obviously not ideal. And it also limits practice because the learning curve is fairly steep, and to get really good at getting images quickly, you need to sort of do 50, 100 acquisitions. And ideally, you do them in a systematic way in a short enough time interval where you can reinforce your skills. So they've made some TE simulators. So they have sort of a mock probe and a little mannequin. And so one technique uses location sensors on the mannequin. So as you manipulate the controls, they sense the location of the tip, and then based on that, they have a computer model of the heart, and they generate a mock image that you would see. They're pretty good for the first maybe 10 hours of learning, but the fidelity of the models is quite low, and you can't teach people how to echo in unusual hearts. So we have congenital heart disease patients. We don't have a normal model in this computer, in this mannequin. And they sell a few pathology models, but it's very limited. There's sort of 3 or 4 pathology models, and they're extremely expensive. So the whole setup costs about $70,000. Each pathology models cost $3,000 or $4,000. And then you have a probe that's semi-realistic, but then the rest of the interface is the computer. It's not an actual ultrasound machine. And it'd be much better to be able to have something where you can use a real ultrasound machine. So people know how to press the different buttons, because on top of manipulating the probe, you have to know how to optimize the image. So there's a lot of things about adjusting the gain of the image, the compression of the image. There's a lot of adjustments that you make on the machine that you can't do with the simulator. So then they have another kind of simulator that's essentially an echogenic molded heart. So you put a real probe in with a real machine, and that one solves some of these problems, but that one, the heart is static. And again, you have a problem with having pathology models. So you have a normal model, but you don't have models of different disease states. And again, that one is also in the $30,000, $40,000 range. So one of the things we're doing in our lab is trying to develop ways so that you can, if you have an interesting case, you can take the CT, if the patient happens to have a cardiac CT, we can make a 3D printed model of their heart and make a 3D echogenic model of their heart pretty cheaply, so that we can then have a library of the digital files online and describe the techniques that people can use wherever they are to make these teaching models and make them for our own use here as well.
Fantastic. Okay, well, I guess that's it. Thank you so much for your help and your time. We really appreciate it.
Oh, no problem. So my question was, for your course, how's your course structured? I didn't actually. What is the goal of?
So essentially, we're supposed to interview with you. Our group, we're supposed to take this video back to the rest of our group. Everyone's supposed to watch it and then kind of generate ideas on what your potential needs could be. So things that we could ideate for to find a solution for you. And then we all discuss those needs and then see if there's something specific that we all could find a solution for.
Okay. And the scope is sort of anything that's information technology related?
Yeah, really anything.
So it doesn't have to be limited to 3D modeling or printing or anything like that?
No.
Any kind of information technology application?
Yes.
Okay. Great.
Yeah, hopefully that helps.
Yeah.
Okay.
Well, yeah, thank
Okay,
you so
perfect.
much.
Thank you
Okay.
so much.
Oh, you're very welcome. Take care.
Have a good rest of the day.
You too. Bye.
Here.